Good morning, everyone, and welcome to our first Wellness Grand Rounds. My name is Deirdre Conroy, and I am the Department's Psychiatry Wellness Advocate. My role as Wellness Advocate is to improve our workplace well-being, to reduce our professional burnout, and to find ways to create a caring, safe environment where faculty, staff, and learners in our Department of Psychiatry and more broadly Michigan Medicine can thrive. We have a great lecture for you today with dynamic speakers and panelists. Before we begin, I need to cover some housekeeping notes. So first of all, please see the activity information sheet in the chat box that Fawn will post. And second, please use the Q&A feature for the question and answer session at the end of the lecture. Please don't use the chat for questions. And lastly, the link to the PowerPoint presentation and exercises will also be in the chat box. Our speaker today is Dr. Patricia Rockman, who will speak about mindfulness in healthcare, reducing healthcare provider stress. Also joining us are our panelists, Drs. Tony King and Dr. Todd Favorite. Dr. Rockman is a senior trainer and expert in mindfulness-based interventions. She has been instrumental in our efforts to create a Center for Mindfulness here at U of M. This is led by Dr. Favorite, Dr. King, Dr. Fresco, Nicole Labrie, and Jim Svensson, as well as many others at U of M Psychiatry and the Mary A. Rackham Institute. Please join me in first welcoming Dr. Tony King, Assistant Professor of Psychiatry and Faculty Associate at the Institute for Social Research, and Dr. Todd Favorite, Director of Psychological Clinic at the Mary A. Rackham Institute and Clinical Associate Professor of Psychiatry. And now Dr. King will formally introduce our speaker.
Thank you so much, Deirdre, and it really brings me a great deal of delight to introduce Professor Pat Rockman. I think she's just a wonderful leader in the field, generally of faculty and medical education, and in particular on mindfulness. And she's going to talk today about the very important issue of self-care in healthcare. So Professor Rockman is Associate Professor at the University of Toronto, departments both of Family Medicine and Community Medicine and the Department of Psychiatry, and also the Director of Education and Clinical Services at the Center for Mindfulness Studies in Toronto. So she's a physician and certified psychotherapist in Ontario, and she has academic appointments at the College for Naturopathic Medicine in Canada and the University of Fraser Valley in British Columbia. So she was awarded her medical degree in 1989 and has been really highly active in professional medical education for the last couple decades, including developing curriculum and teaching cognitive behavioral therapy with psychiatric resident physicians and community physicians and family physicians, and very active in community education. So she's done some really interesting and wonderful scholarship on education, has been a real innovator and leader in the use of remote learning techniques, and has won a number of awards, including the Kaspersky Leadership Award for the Ontario College of Family Physicians, and a number of other awards, which are too numerous to really go through. But I also loved reading her CV to find some things that I didn't know about her, and that really is a testament to Pat as a Renaissance person. She's also an accomplished and prolific performer, filmmaker, and poet, and including clown performances of Love Struck and Mirror, Mirror Off the Wall. And she's won a number of awards for her artistic performances and for her poetry. I think Pat is best known throughout the world for her work as a master therapist, educator, and trainer in mindfulness-based interventions. And you'll hear, many of us are familiar with that. Pat will describe that in detail, but really mindfulness-based stress reduction and mindfulness-based cognitive therapy. Pat has had decades-long collaboration with a number of the leading figures in the development and professional dissemination of what we call MBIs. Those including Zindel Siegel, who developed MBCT, Susan Woods, Charles Williams, and a number of others. She's written a number of highly influential articles, chapters, and books, and in particular on this topic of what's called mindful inquiry, which is sort of really the heart of mindfulness-based interventions. And we've had, so she's taught, I think, generations now of mindfulness teachers throughout the world, and including here in Ann Arbor. So last year, Dr. Faber and I had the wonderful opportunity to bring her to do what's called a mindfulness-based stress reduction teacher training intensive. And I just want to read very briefly that a little blurb that I wrote for her webpage, because I think she's really an incredible, just a brilliant and charismatic and deeply knowledgeable teacher, but she's also very caring, and she really clearly embodies mindfulness in her speech and her movement and her presence. She challenges us to be truly present in a manner that's both authoritative and precise, yet has a spaciousness, a depth of heart, and a humanity that allows even some mischievous sparkle to shine through. And this is, I didn't know about her clown training before. This is wonderful. And I really think that her teaching is steeped in her knowledge and experience and wisdom, and really the integrity of how she embodies the theory and practice of mindfulness. So I'll leave it at that. I could say more, but I have more important things to do. So Todd, were you going to say something, or should we go directly to Dr. Rockman?
I think you've said it all. I would just reiterate that the training that Tony King and I and several others within psychiatry and the Institute at Mary A. Rackham had last summer with Pat was truly inspirational, and has really led to really galvanize the push to really create this training opportunity and dissemination of service delivery anchored in mindfulness-based interventions. So.
Thank you. Thank you. That's a lot. I just want to, before we start, I see that Sagar's online, and I just want to say hello to Sagar Parikh, who has been an important mentor to me and colleague. And he really taught me a lot about medical education, and particularly in psychiatry. So I'm just saying, hi, Sagar, wherever you are. So let's just I'd like to just take a second, because I feel actually quite emotional now and nervous. So if we could just, because we're online so much of the time, I think it's very difficult. And it's, given that the topic is mindfulness, it's really easy for us to lose our attention, and it's hard to be staring at a screen all the time. So I'd like us to just stand up for a moment wherever you are. I'm just standing. And of course, I can see some of you, I see a few people that I asked to stay here with me. So just coming to standing and taking a moment to take in the space where you are, looking from side to side, moving the head, taking in the room, and taking in the sensation of sight. And perhaps if you're at a window, just seeing what is to be known, or how things remind you of home. And then closing the eyes for a moment or so and checking in with the body. And just arriving here in this moment of this talk and these rounds with all these people that I can't see. Welcome. And checking in with what is here in the body, mind, and sensations. Thinking, emotions, and impulses. And just getting a handle on your inner experience. And then taking a moment to narrow the attention to the physical sensations of breathing in the abdomen. With the eyes closed or half open. And attending to the movement of the belly as it rises and falls. And then expanding, bringing attention to the entire body around the breath. Noticing sounds that pull the attention, but coming back to this wide spaciousness of body. And then letting go of this brief practice. If the eyes are closed, opening them once again, bringing the attention back to the room, and then coming back to sitting and bringing your eyes back to the screen. Okay. All right. So I'm going to use the slides, not through the whole thing, because I really want to do my best to make this interactive. And they were talking about not being able to use the chat, but I'm hoping that we can together, but we'll see what happens. If we can't, I'll have to use Fawn and Deirdre, or maybe Tony and Todd as mediators, you know. So this is the usual presenter slide. I don't have any commercial interests or conflicts. Okay, so what are we doing right now? Well, I know that some of you have experience with mindfulness and some of you don't. So if you could just go to the bottom of your screen, and somewhere there you should be able to find a hand. I think if you go to the participants section, and then I just would like you, because I can see all of you, I can see your names, that's what I can see. If you could just raise your hand in terms of if you have any experience with mindfulness. Okay, nice. Yeah, here they come. Great. Oh, I like Sagar's hand. It's a different color. That's good, Sagar. Smart. And Sajni, this is great. You know, this is important, right? Yeah, you know, you got the yellow hand for the white people. Okay, yeah. Anybody else? This is good. All right. Okay, nice. Okay, so maybe, I don't know, roughly half of you. Okay, nice. Okay, thank you so much. This is helpful. All right, so we want to look at some of these assumptions and principles, look at some of the key intentions. We'll do some practice, and we'll look at a little bit of the evidence. I'm not going to talk a lot about the evidence, although there is more than I will speak to on your slides, but I sent the slides to all of you so that if you need them, you have them. But I don't know about you, but I rarely go back to look at them, be that as it may. Okay, so we did, actually what we did as our opening practice was a 3-minute breathing space, although it was probably just maybe a couple of minutes, but this is a core practice from mindfulness-based cognitive therapy, and it's something that I tend to do a lot. And it is the practice that after people complete these programs that they tend to carry on much more than anything else. So be that as it may, let's move into looking at stress and burnout. Because I think, you know, as many of you know, if not all of you, of course, Jon Kabat-Zinn, you know, I think is really, you know, one of the greatest, if not the primary contributor to the medicalization of mindfulness. And in this, we're not talking about mindfulness as pathology, but rather we're talking about it as a treatment modality, right? Which is not what as it was originally intended for when it was first created, you know, 2,600 years ago. Although some people do refer to the Buddha, which is where, of course, mindfulness, at least in the form that we teach it, originated from. Some people do refer to the Buddha as a doctor. He evidently was quoted as saying this, but really, in fact, it was not a medical treatment, as we know, but it has become one. So why I speak about Jon Kabat-Zinn is because it's really interesting. You know, when he started mindfulness-based stress reduction, if he'd called it Buddhist-based stress reduction, I don't think there would have been the uptake, you know? So when we think about this, we see how stress, you know, since the 40s with Hans Selye actually, or the mid 50s, really entered the medical lexicon. And he defines the stressor as any external condition that arouses the adaptation response, and that condition is neither necessarily positive or negative. And we can think of stress as the response or reaction to any demand or problem. Of course, this is normal. You know, we all face stress. So when, you know, you think about it, like, when does stress become a disorder? Well, actually, it's not a discrete diagnosis or disorder. In the DSM or in the ICD-10, although it is associated with other conditions, of course, such as post-traumatic stress disorder, or stress fractures. It is a messy term, which is totally embedded in Western culture. I think I can't speak to other cultures, but, and this is important because it's a vague, messy term, difficult to define, and therefore difficult to research. However, when we use the word, I'm so stressed, I think we all have a sense of what we mean, right? Although of course it may mean different things to different people, we have a relationship to this. And this is something, I think that many of us can relate to. Maybe if you're under 40, maybe you don't feel this way, but I suspect if you're like me, far over 40, I often feel like this, and this morning was no example. So moving on to this, I know that I know that there are many different people. I don't know the backgrounds of all the people who are here. I'm assuming there are a number of physicians, but another of other healthcare providers. So we know that impairment in healthcare is common. We know that many physicians and other healthcare providers become impaired over the course of their career. And we also know that burnout is significant. Okay, so burnout, and then we have stress. Well, what's the difference? Well, first of all, stress is something that we can consider a normal part of life. If it becomes chronic, then we become often unable to function, and also it has been associated with many diseases, although it is not seen as cause of those. Okay, so burnout then. We see that burnout is very prevalent, and we see 48% of female physicians versus 37% of male physicians have burnout symptoms at this particular time. This is reported in 2020. This is big, and we see that more than 50% of American physicians now have at least one symptom or sign, and the prevalence is very high among nurses. So what is burnout? I'm sure you all know, but just so that we are in this moment speaking on the same page, we know that this is something, there are stages of burnout, and we know that, initially we may be working harder and be excited, and by the end we are quite dysfunctional. Interestingly, burnout actually is a diagnosis in the ICD-10. It's related to occupation. That is what burnout is related to, occupation, whereas stress is much broader. So at least for burnout, we have something narrower, and maybe we can, have a little bit of a better handle on that, be able to speak to this in the same way. And developed by Maslach, and well, people earlier, but Maslach particularly talked about these aspects of burnout: emotional exhaustion, cynicism and depersonalization, reduced professional efficacy and personal accomplishment, okay, where we often start to feel incompetent, we're inefficient, and so on. And then this, of course, can lead to chronic sadness and mental and physical fatigue. And then you can start to see how, okay, is there a relationship here to depression, to anxiety, and other, affective and anxiety disorders. With respect, there are many models around how we can think about burnout, but I think in healthcare, particularly, one of the things that's important, particularly for people who are in middle management, or I would suspect maybe nursing, particularly social work, where there is high effort and sometimes low reward, high demand and low control. Now, as the physicians in the group, we may not have so much control, but we believe we do. And so we behave as if we do. We tend to be, I don't know in the States, but often in Canada, we're in this, we have this mandate to control our own work. We're quite independent, individualistic. I'm sure it's quite the same in the States. And even though we are controlled by various governing bodies, I think we often don't behave as if we often are not working as employees for an organization. So when we are incredibly burnt out or stressed, this is something that sometimes comes. And I know for me, when I get my emails, it's like, no, Thursday's out. How about never is never good for you. This is like often how I can feel about what's happening, Okay, so I think in talking about healthcare and provider stress and burnout, I think one of the things that we need to remember, and this can be difficult when we are not necessarily functioning in a society that is collectively oriented, it is more individually oriented. And so healthcare organizations and systems have a big role to play in healthcare provider stress and burnout. And I think one of the things that's problematic potentially about mindfulness, and I know that I am not the first to say this, and I just read it recently when I was researching for this talk, that, often there is a perception, and I do think it's true, that systems are bringing in mindfulness, adopting it for employees, for mental health, and for productivity and, efficiency. And what they're really doing is they're downloading systemic problems onto the individual. And I think this is really important. And I think it is also important because mindfulness, the way it has been taken up within our society, within Western society, broad-based, and I think within, the medical field, it is a treatment for individuals. It is seen as something for which the individual is responsible. And, then you can see how congruent, if people are engaged in mindfulness practice for themselves and they're not part of a community, or what is in what is terms often referred to as a sangha, if you're not part of a community, all of these things just become dependent on you and your abilities. And I think that many of us know that we really do much better in community. We know that you cannot make individuals working in healthcare responsible for inefficient work process, excessive workloads, and all of this stuff, right? It's important that we begin to enhance organizational support structures and support from leadership. So I think this is hard to hold in mind because, of course, this means then that if healthcare organizations are taking up this work, are they really willing to make some significant changes for those who work for them or with them? Or is it really a kind of tokenism? Okay, so I talked about this already. All right, so let's do a quick practice once again. So closing the eyes and just turning the attention inward, if you would, for a moment or so. And bringing attention to the physical sensations of breathing. Breathing in and breathing out. Just attending to what is noticed here. And then opening the eyes now. And just, if you could just pop into the chat, just pop into the chat what you noticed. What did you notice there? Anything at all that showed up for you? Okay, calm and warmth and stillness. Okay. And perhaps how calm showed up. How did you know? You can just pop that in. Peaceful. Kyle saw his mind wandering, saw the attention being pulled into his future to-do list. So we see how the attention so noticeably moves of its own accord. And Tony noticed, a woodpecker outside. That's so great. All right. Okay. And then awareness of body sensations, tension. Okay. And peace, sounds, other sensations. Right. Okay. Isn't that interesting how the background noise became more noticeable as we all of a sudden just tune in. Other things in our field of awareness become more apparent. Okay, more to-do lists, a sense of centeredness. Still being in the past with an email that pulled the attention, a Zoom call, settled and relaxed. Okay, great. Thank you so much. Okay, so now, what has this got to do with mindfulness? When you think of mindfulness, what comes to mind? Please just put that into the chat. Just anything at all. While John Kabat-Zinn says there is no right or wrong here, in this case, there really is no right or wrong. Okay, when we think of mindfulness, awareness and metacognition and being present, yes. Attending to the senses, absolutely. We're using the body as a training ground, right? For attention, we see focus, clarity in the moment, seeing what is, paying attention to the present without judgment. This is nice if you can get it, the without judgment part, I guess, and also if you can stay attending to the present, whatever that happens to be. Okay, nice. All right, okay. So there are many differences. Oh, relaxation, also nice if you can get it. Okay, mindfulness, what is it? Okay, there are many definitions, right? And there are, the one here you see by John Kabat-Zinn is the most common operational definition used in psychotherapy research, but it is an operational definition, right? It is getting at what we are, if you like, doing. As you wrote here, we are paying attention, as Kirk said, we're paying attention without judgment, if so, to the present, whatever that happens to be, in a particular way. The particular way is deliberately, on purpose, right? And then Susan Weds, myself and Evan Collins wrote this book on MBCT, and we came up with our own definition because why not? Attention to one's present moment experience, bringing a kind of curiosity and inquiry into that experience. And I think for me, you know, what I've come to see, you invoking authority through experience, is that curiosity and the investigation of your experience, even if it is unwanted, can really help us in times of difficulty, when we are feeling highly reactive, when we are feeling really stressed, when perhaps we are feeling burnt out. We can start to begin to investigate experience and to get a bit of distance, diffuse, decenter, to be able to watch that experience without necessarily being so stuck, so caught, so immersed, right? As a woman I work with says, immersed by the octopus on your face, which is often how it can really feel when we are, you know, in the thick of it. And just know that in the scientific literature, mindfulness is referred to as a state, a trait, a spiritual path, a cognitive process, or mental faculty. Within our cultures, generally, it's something that happens in the workplace, in education. It can be a protocol, a curriculum. There are so many things it can be and so many definitions, which also starts to beg the question of what is it exactly and what are we doing? And you can see already that when we think about healthcare and health and research generally in this field, it's tough if you don't have, you know, a clear definition of what it is you're actually working with, or necessarily consistent outcomes. So what we see in healthcare, and this is really what we're focused on today, is mindfulness as a practice and as a mode of self-care, and perhaps even as a mode of enhancing a therapeutic relationship with yourself. So when I say that it's not those definitions, this is because it includes all of these other things, you see. Mindfulness is really also, it is about learning. Hence, mindfulness involves memory. So this starts to get complicated, right? Because if we're talking about mindfulness being paying attention to the present moment, non-judgmentally, and we're always in the present moment, then where does memory fit into this? You see, it starts to get quite complex. So I just speak to this because I think, you know, it's really practically a meme in the society now, mindfulness, if I even really understand what a meme is. And, you know, I think that what happens, of course, is this beautiful practice and lovely work is so easily diluted and simplified in a way that where we can miss so many of the aspects of it that really speak to its complexity, right? And so I think thinking about this, we know that mindfulness requires learning. And of course, if we're running things like 8-week programs or various other modalities that can go anywhere from a day to months, obviously we are teaching people something. And so we need to understand that we are bringing up what is learned also. We're learning to access that, whatever that is, particular intentions, particular attitudes, and then also particular practices. How do we work with difficulty and challenge when it arises? Yeah, because I often jokingly say, because my professional mindfulness training really began in mindfulness-based cognitive therapy. And we started the center, we were doing MBCT, doing mindfulness-based cognitive therapy. That's what we were offering and training healthcare providers to deliver. And so sometimes I forget the joy and the beauty of the practice, because in these formal modalities and in other places where we would practice, we are also attending to both the joyful and the wondrous as well as the difficult. But I can sometimes think of myself as the queen of misery, because when we're involved in these practices working with people with depression or anxiety or trying to prevent depressive relapse, and they have these internal cognitions and beliefs about themselves, this is often where the work goes, is into working with the difficult. So it's important to remember that the practice is broad. And of course, in mindfulness-based stress reduction, the reach is broader. And yet that also has its own difficulties. So why be in the present? Because we can do this. We can disrupt these negative spirals of rumination and worry. We can begin to unhook from things that spin us down into negative mind and mood states, such as depression or just low mood. Also, it allows us a different relationship to experience. So one of the questions when I asked you about, what are we doing with this? And somebody wrote attention to the senses becomes this body, and attending to the senses becomes another place, as Norm Farb, a neuroscientist, says, from which to witness experience other than the voice in your head. So it's not that you're getting rid of thoughts, but rather we start to develop this capacity. Doesn't mean we're not in pain. It doesn't mean that we don't suffer, but we're not so caught up. We can begin to see this as a state that comes and goes, even if it lasts for quite a long time. And then this ability to step back in that way allows us to perhaps have more options, to see that there are more possibilities about what we might do next in terms of taking skillful action, thinking about whether something needs addressing or not, whether we can just sit with it. Can we let it go if it's already happened after all? How many of us, when something has happened to us that's painful, it just sits there, both in our present, even though it's gone, we cling to it. And then the last thing that being in working with mindfulness and working with this way of attending to present moment experience with this particular perspective is it allows us to recognize the imperfection of life, the impermanence of life, that nothing is certain, which I think all of us through this period of the pandemic and racial unrest, we have become so aware of so much of things that some of us took for granted, that we considered positive or difficult, or, the illusion of certainty. And, this, of course, for those of you who have any Buddhist background, know this is ripped off from the 3 characteristics, which is a really central Buddhist concept and can be very helpful with mindfulness. Because if you stop trying to always get it right, you stop aiming for perfection, which is, a common problem in healthcare, right? Healthcare providers, we don't get kudos for not knowing in healthcare, you do not. And yet you don't get kudos for being uncertain. And yet this is just so antithetical to the way things are. So if we could perhaps begin to take a good enough view and to really internalize that things are imperfect, then perhaps we could drop the stick that we tend to kind of hit ourselves with, you know, particularly healthcare providers, I think, no matter what discipline you're in. And then also this noticing of impermanence. This is really what is meant by the recognition. It's not just knowing things are impermanent. Stephen Batchelor, who's a Buddhist scholar, some of you may know, brilliant man. And I had a chat with him writing the book we just wrote on MBSR because he's so able to bring this work into this time and this place. He really is a secular Buddhist. And so, you know, he talked to me about that. It's not knowing that things are impermanent. It's noticing it. It's recognizing it. It's seeing it when it happens. And so these practices that we engage in when we're paying attention, for example, if you just close your eyes again now for a second and just bring your attention to the sensations of breathing at the belly. And you notice, you inhale, a breath begins. There's a pause. Oh, it's gone for a moment. And there's an exhale. And then there's another pause. And then a breath arises again. And it passes. And so we notice that. You can open your eyes now again. So then you notice that, unless you don't want to open your eyes, that's okay too. And so in the noticing of that, we start to have the embodied experience that everything comes and goes, which means our pain comes and goes. Even if we have chronic pain, the severity of it comes and goes. The intensity comes and goes. Our grief comes and goes. And then eventually we are here and eventually we go too. So while this can be painful, at the same time, it can be a big relief, right? Like a bad day, I'm having a bad day. It's gonna go. I'm not gonna have a bad day every day. And if you're having a bad day every day, maybe you need to change your job or get some help somewhere else, you know? Like this could be a signal, seriously. But, you know, or I have a fight with somebody. If I can remember that it's not gonna stay that way the whole time, this can bring some ease. Or even when we're depressed or anxious or any state, the joyful too, they come and go. So if we cannot get too attached, if we cannot grip onto these things, wanting to keep things as they are, this can help reduce our suffering, perhaps small s suffering, but it can reduce our challenges. And then the impersonal. Sadly, you know, really life is impersonal. Now this can be hard to take. If I think my husband didn't think of me when he forgot to bring home whatever, the milk, and cooked dinner too late. And so I'm mad at him because, like, why isn't he thinking of me? If I can remember that actually maybe something else was going on in his head and it was just thoughtless, then maybe that brings a bit of ease. Or if you're working in an OR, I don't know if there are any surgeons here. Hands up, any surgeons in the room? I don't know that any surgeons are coming to a psychiatric round, but if you're in the room with a surgeon in the OR and they're screaming at everybody, you know, it's very difficult not to take that personally. But if we're able to see that actually this has nothing to do with me, and in some ways nothing even to do with them, this may prevent us from getting so caught up, so stuck. But this is much more easy to talk about than to do. Okay. So what we are doing in mindfulness-based programs is we are working with exploration, investigation, and regulation. That's what we're doing in mindfulness. And this is what we're doing when we're bringing the practice to ourselves. We're exploring our experience, investigating it, and then with respect to our emotions and attention, working to regulate ourselves. In Buddhism, the last one is liberation, but this is not our purview. If you get that, that's great. But if we at least can get regulation and learn to work with our attention to disrupt negative and mind and mood states, this is helpful. So central elements, I'm calling them elements, of mindfulness-based programs is that we are working with decentering, and there's some increasingly good evidence that this is an important moderator, decentering, and that this skill in decentering evolves for certain people long after the programs that they take. It's indirectly tied to home practice. We don't really know how much home practice people need to do. We think that regularity is more important than length, but we don't really know. We're also working to reduce experiential avoidance. And this is important because turning toward difficulty, we know, can help stop the perpetuating of certain negative states. We learn to process them differently. This, by any other name, is exposure. Doesn't really get talked about that much in the mindfulness literature that way, but really mindfulness is about exposure, and that with awareness and noticing. Michelle Kraske's work, she talks about this ability to really understand and have awareness. She does a lot of, she's a CBT or in anxiety, quite well known, I'm sure, to most of you, but this understanding of the mismatch between our expectations and outcome is critical to reducing return of fear. And this is what we're doing in mindfulness, I think, if we are able to access its potential, is we recognize our thoughts and emotions, we recognize our predictions, we have a practice, we turn toward that which we would rather not. And then something may start to shift. And then, of course, we talked about the disrupting of rumination so that we're not elaborating on our thinking. And then also, it would seem another important variable for mindfulness-based programs is bringing compassion. And I think curiosity to your experience. Compassion sometimes is a hard one. Show of hands, how many of you have taken self-compassion programs, like mindful self-compassion? Anybody? Right. Well, yeah, I'm in the middle of one and taking one, and I've done some of it, and I really struggle with this. Okay, I really have a hard time. I'm not going to give you all my opinions and views about it because I know I have like a ton of bias, even though I'm taking it and I think, is it helpful? I think so. But, it's interesting, this idea of compassion for the self and others, bringing compassion to our experience. I forget who said it. Maybe Tony knows. One of the early monks that came to the West, who brought mindfulness to the West, talked about how North Americans have so much self-loathing, which is kind of interesting since we're so individualistic. Do you know, Tony, who said that, talked about how much self-loathing we have?
I know that the Dalai Lama was quite perplexed
by that.
By self-loathing. Yeah.
Okay, so maybe it was the Dalai Lama. There you go. I don't remember anything. It's always good to have people on board who have better memories. Okay, so I think he was perplexed, and somebody else I think said it, but anyway, it doesn't really matter. The point is, this is something that we tend to be known for, and I don't think anyone's ever done a study on it, but I do know that Willem Kuyken did work with respect to depression and preventing relapse and showing how compassion is an important variable and how difficult it is for those of us who suffer from negative mind and mood states, from depressive disorders, to bring compassion to ourselves, and I think many of you could, you can kind of extrapolate why.
And by the way, Dr. Rockman, Dr. Fresco says Jinpa.
Ah, okay, Jinpa. Yes, thank you. Thank you very much. Yes.
Of course he would know.
And Jinpa, Jinpa, so David Jinpa, he started CCBT, is that right? Or the Compassion Care Center, is that right? Maybe you could put it in the chat. It's actually, I think it was started at Stanford, I believe. Anyway, so what are we doing here? So here we have what we were talking about. We've been talking about this. Mindfulness is about coming to know the full range of your experience and then how we might respond skillfully. And this involves this mindfulness of body, attending to all of these aspects of the body, to thoughts and emotions, and seeing emotions as sensorial correlates, because emotions show in the body, there's no question. And we can investigate them there instead of in our heads. and seeing thoughts as mental events, as sensations of the mind, rather than the facts we believe them to be. And then we're working with our attention in these many ways, and both with focused attention and open and receptive attention. We begin to train our attention in a focused way. This helps us hopefully to be able to direct it, to place it more where we want it, so that we have more agency, right? And, you know, I think one of the things that happens to us when we work in healthcare and we're working under these incredibly stressful conditions is we lose our sense of agency and autonomy, because we are in a situation and a system that we really can't change. But what we can do is begin, oh, there it is. Thank you so much, Tony, compassion cultivation training. So, you know, we can begin to have options around how we work with our reactivity and our states, and then our skillful responding, and who we might go to for support if we need to. If again, we can allow ourselves to be able to have a willingness to accept this is where we are, wherever that is. What I discovered recently going through, you know, a difficult situation was that I really had this notion I should be somewhere other than I was. I should be cooler, I should be calmer, I should be more understanding, more accepting. And, you know, and this was causing a lot of grief. And then waking up one day and realizing, actually, I'm not. I'm really distressed by this situation. It really doesn't feel okay. And I need to set a boundary and I need to look after myself. And all of a sudden, this willingness to actually be willing to accept where things really are rather than I would like them to be, all of a sudden reduced a lot of the distress. And this is another, you know, definition of suffering, which is wanting things to be other than they are, right? Okay. So you know probably all of this or most of it. So these are the most common modalities and applications. And we, what are called the most mindfulness-based empirically supported treatments are MBSR, MBCT, DBT, and ACT. Of course, DBT and ACT are often referred to as more mindfully informed because they don't have mindfulness-based meditation practice as central to their work. But they all involve this notion of decentering from experience, of getting this different relationship to experience, meeting it in a different way. Okay, so I did actually manage to go and look at some of the literature, and it's interesting. There's not really that much literature on healthcare providers and mindfulness-based interventions. But this meta-analysis that I looked at, you looked at 41 studies with just over 2,100 participants. And they looked at two classes of well-being outcomes, deficit-based and asset-based.
Hi, Lucy, baby. What are you going to have for lunch?
Fawn, I think you're not on mute. Fawn, can you mute your mic?
I don't know what I'm going to have for lunch, but if I can be your baby and you'll feed me, that would really be great. Or all of us for that matter. Okay. So anyway, we know like predominantly the focus on healthcare provider research is on deficit-based, right? Anxiety, burnout, depression, stress, distress, anger, and so on. And not very much of it is actually based on life satisfaction or empathy or mindfulness or compassion. That's okay, fun. It just, you know, serves to kind of make attention more salient for us all. But it's interesting, they showed that MBIs do have positive outcomes with moderate effect sizes, but sadly, there was no significant difference for emotional intelligence and emotion regulation. So you might say, you just told us all this stuff about emotion regulation. Is it true? Well, of course we don't know. We know that one of the problems with evidence is what is true one day is not true the next. It's constantly changing. And, you know, while science is for many of us our current system of truth. It is one way of knowing. And the research still is very early. The studies are not great. They have many limitations, as you see. And, you know, I think that this is also the case with much of the research generally, is that mindfulness-based research in 2 decades, it's changed somewhat, but it still uses a lot of passive controls. A lot of the quality of the studies are inconsistent. We have very few community effectiveness trials. So, you know, while there is a lot of literature, we still really, if you like, are really early on still in establishing what is really going on here, what is really effective, what are the moderators, what are the mediators, and so on. Okay, so let's just take a 3-minute breathing space. We're going to do an exercise. So closing the eyes once again and turning the attention inward. This is the first step of the 3-minute breathing space. Checking in with current experience. What is here? Thoughts, emotions, and body sensations. Getting a handle on your internal landscape. And the second step. The second step is narrowing the attention to the physical sensations of breathing at the belly. And the third step is widening the attention to the entire body around the breath. Any and all sensations inside the body. And at the surface of the skin. And then letting go of this very brief practice. And taking this more widened attention into your next moment by opening the eyes. And then just taking a moment now and popping into the chat, this 3-minute breathing space, you know, it's portable, right? Like we just have ourselves, it's all inside us. So how might you use this in your work? If you were to, how could you use this? It's a check-in, it's a reset. How might you use it and where? You can just pop that into the chat, please. Okay, taking breaks between patients to clear the mind and reset. It's a brain break. I like that. I took an emotion-focused therapy training workshop the other day, and they talked about brain hacks. Could be a brain hack too. Use this to briefly center myself before seeing each patient. Yes, especially, you know, if we have a difficult encounter. Prep and recentering before starting the clinic or before meetings. Yeah, you see, I started it before this when we stood up because I was feeling kind of agitated. In the midst of a hectic clinic, yes, you know, you could just go to the bathroom or you could just do it for 30 seconds with your eyes open. Okay, before, yes, in between sessions, yes, with more difficult, okay, in between patients or with patients. Ah, that is very smart. Okay, this is very smart. You know, this is, you could just start sessions with patients this way, right? Oh, you know what? We're in the middle of the pandemic. Things are so stressful. I just learned, I have this new practice. I think we should start doing this together at the beginning of our sessions as an experiment, you know, and then it helps you and it helps them. Because of course, in our sessions with patients, we are in a relationship, right? I know it's supposed to all be about them, but it really isn't. Okay, making the transition between work and home. Absolutely. How do we let go and move into the next thing? Yeah, nice. Elizabeth says, making it a regular part of practice with clients. Okay, use it to interrupt or break unhealthy habits. Yes, this is smart because, you know, you tune in. Ah, here is a craving. They use a variant of this actually in MBRP, you know, for relapse prevention of addictions. Yes, turning, what's here right now? Oh, craving. How does craving feel? Can I investigate craving? And I'm sure Judson Brewer does that too. Okay, nice. Okay, so here are all the things it does. Helps us to continue this interruption of automaticity, hence good for habits. Helps us to parse experience and make it more manageable, and so on. Okay, so now, what are some of your greatest stressors? Just put them in the chat, please. Just don't think too hard. And we know, of course, if you're experiencing it, not necessarily, but it won't be unlikely that others are. And this is lovely. Okay, deadlines, school, the EMR, yes. Shelf exams. I don't even know what that is. Inadequacy at work. Notes. Yeah, well, you know how we can deal with notes, just don't do them. Aging parent, yes, this is very difficult. Aging parents, and especially during the pandemic, it's been so painful. Emails, all of them, balancing many hats. Yeah, that's, I have this wonderful Dr. Zeus image with you, Janelle, with like a big pile of hats on. My dissertation, oh, hi, Emily. Yes, Emily, dissertations are stressful. Finding time to be productive. Preventing balance, yes. Uncertainty, yes, okay. Uncertainty is a big stressor, and virtual burnout. Oh, wow. Oh, that's great. That's great, virtual burnout. And now, Tracy, you just coined the new phrase, virtual nausea. People have been asking about that. I'm gonna say, we created virtual nausea together, Tracy. Oh, that's great, okay. So uncertainty, this is big, because life is uncertain. This is like a lifelong work to come to be with uncertainty, right? Medicine is uncertainty. Healthcare has irreducible uncertainty, and we don't acknowledge this. So the first thing about how we deal with stressors is how do we acknowledge the uncertainty that is inherent to mental health care. Okay, oh, shelf exams are med school subject exams like mini, but I hated medical school. Okay, exercise. Here we're going to do exercise. Okay, so closing your eyes. Oh, if you have a pen and paper, please go get it or have it there. I can't see you. You need a pen and paper, and I want you to put like a 2x2 table. I want you to put thoughts on one corner, emotions, body sensations, behaviors, and then what prevents us from noticing at the bottom. I tried to send this out, but it didn't work. And those of you who are CBTers will know that Evan Collins and Mary Elliott ripped this off from CBT, but it's another way of looking at it because it's not quite linear in the same way. Okay, so hopefully everybody has that and has done it. Yes, they're nodding, at least the people I can see. Okay, so closing your eyes now, once again, for a moment or so. I want you to think of a specific stressor now. Something recent, hopefully something that's not, 100 out of 100, maybe, like a 30 or a 40, something recent. And I want you to notice now what thoughts, emotions, and body sensations come to mind. And if there are specific emotions, naming them. Perhaps agitation is here, or anxiety, or sadness. And what body sensations? And then really bringing attention to those physical sensations, whatever they are, and exploring them, investigating them, even if they're unwanted. And perhaps impulses come to mind. And then opening your eyes and recording your responses on your web of reactivity that actually just looks like a 2x2 table. And then I don't need to hear the stressor. And you write your thoughts, emotions, body and behaviors or impulses. Okay, then I want you first now, write your thoughts. The thoughts that popped into your head that you wouldn't want to say to a group of strangers or even people you know. The thoughts that arose in that moment, just pop them into the chat. Oh, good. Okay, and some people, okay, if there are more thoughts, put them in. If not, just start popping in emotions. Good. Great. Nice. Okay. Okay. Good. Yeah. And then pop in the body sensations that showed up, if any. Lots. Lots. And any impulses. Leave. I'm glad you stayed, Todd. Okay. Anything? Quit. Aha. Okay. Avoid. Aha. Avoid, don't show up. Yeah. Nice. Snap. Ooh. Okay. All right. Now I'm just going back down. I don't want to read these all, but I want you to look at them. I want you to start with the thoughts. I'm assuming everyone can see them. Okay. I want you to look at them. Look at all the thoughts. See what you see. Look at the emotions. The thoughts, my children won't be happy. I'll be cold and upset and incompetent, doubting myself, my efficacy. Okay, then look at all those emotions. Yeah, what do you notice? What do you notice about all those emotions and those sensations? What do you notice? Just pop it in the chat, whatever you notice about those emotions, those sensations, those impulses. But the emotions, I think, and the sensations particularly, what do you notice? Yeah, negatively valenced. Yes. We can't see the whole chat response. Oh, okay. So the thing to notice, what I will say, is that, like we see here, here are the emotions, okay? Guilt, shame, fear, anxious, fear, self-doubt, anxiety, anger, anxiety, withdrawal, retreat, tight chest, gut reaction, stomach dropping, tension. This is now the physical. Tension, chest tightness, heart racing, queasy stomach, difficulty breathing, tightness in the stomach, tight chest, pressure behind the eyes, tense in the limbs, brain fog, hard to think, impulses, leave, quit, avoid, don't show up, turn inward, give up, sleep, snap, just walk away. Okay, negatively valenced. Okay, so everyone sounds on the verge of breaking. Yes, so this is what happens when we do this exercise. Yes, shared experience. The experiences are shared and very similar. They're very similar, right? This is not infinite. Our reactions are not infinite. This is important to know, right? They're limited. Okay, and closing your eyes again, just for a moment. Let's just let go of that for a second, just to bring a little ease. So dropping the attention down into the belly, perhaps even placing a hand on the belly. Then breathing, belly rising into the hands and falling. Just being with experience as it is. Widening now the attention once again to the entire body around the breath. And then taking 3 deep breaths. Okay, and then opening the eyes And I'd like you to just put into the chat, what could be the value of doing an exercise like this, of writing this down in terms of managing difficult states, stressful states, states where you're feeling like you're not coping well? What could be the value of doing something like this? Okay, so people are writing, again, shared experience, awareness, and thinking about why is awareness important, or knowing what is important. Why is it important to know? Some people would say, like, I don't want to know what's going on. Helps you circumnavigate, perhaps, avoidance of the stressor. Okay, so if you know what's going on, maybe you can navigate it, maybe you can make a change. Able to see the feelings from outside. Once you name it, you can better control it. Yes, as people know, Siegel's name it to tame it. Or Rick Hansen or whoever said it, able to see the feelings outside. This is important, right? We're externalizing things, building awareness of when those feelings are starting to build up. So if we have this kind of awareness, then maybe we can do something else before they take hold. I always notice I am holding tension in different areas of my body, so I can decide to relax them and feel less pain, soreness, tension, fear, tension later. Okay, so you see, this then, what Amy's identifying here also is that sometimes awareness is not pleasant, but it may, not always, but it may allow us to do something different. And also, we see how tension is often, if you like, we can see it as a kind of resistance to what we are experiencing, not necessarily, but it fits with this next slide. And Shinzen Yang, meditation teacher, he talks about that suffering equals pain times resistance. Resistance we can think of not wanting things to be as they are, or holding the body. Oh, I'm holding my shoulders up. I'm so tense. I'm so anxious. Oh, okay, can I just kind of let go? So we see in terms of healthcare versus what mindfulness is doing, at least in my mind, healthcare focuses on pain. If you think about it, disease, death, illness, and so on, so many aspects of what we might consider painful aspects of life, literally, or other things. Mindfulness is focusing on how we meet those experiences. Are we resisting? Are we willing to have what is here? And so, sometimes they'll say, if you're not willing to have it, it will have you. Probably got it from somebody else. But and acceptance is not resignation. Acceptance does not mean you don't take action. Acceptance means you go, this is painful. This is here. Okay, now what? Versus, oh, I don't want this. Why do I have this? I have the worst pain of anybody, and so on. I'm the most technologically useless person in the universe, and so on. Rather, oh, this is a painful moment. Okay. This doesn't mean we become a doormat to our experience, but rather it means that we can then turn toward it and work with it and decide what is actually the most helpful thing to do next. And so I think when we work in healthcare systems, and particularly when we work in institutions, I think institutions are very tough. I think that they can be quite toxic. I think that we very naturally will have many painful moments, as well as we may have community, and so can have a lot of support. But we may come up against many situations that we don't like, that we don't want. And humans are really often controlled by what they like and don't like, leaning into what they like, pushing away what they don't like. And so part of what we can, which can then, of course, make everything bigger. So in working in healthcare, paying attention to what is difficult can then, rather than avoiding it or ignoring it, which can perpetuate the problem, it can allow us to see things differently and really decide in a much more skillful way what we might need to do next. Shapiro, it's quite old now, but people still talk about this model, this mechanism of mindfulness, since we don't really know, what the mechanisms are. But she, really came up with this idea, like think of awareness as the big sea that we are in, and that we bring a particular kind of awareness to our experience. And attention is like the submarine. Attention is like the submarine that is moving through the waters of our awareness. You know, we're directing it. And intention is this deliberateness, this, you know, choosing where we want to go. And then the attitudes, mindful attitudes, which can be helpful, particularly, I think, for healthcare providers, given that many of those attitudes are socialized into us in our training. And then I think often we get quite worn down and may lose these. You know, they are things like patience, trust, kindness, compassion, you know, non-judgmental, acceptance, and we've added curiosity. You know, John Kabat-Zinn came up with a specific number, but there really are many more. So really what we are doing here is we can think of responding mindfully as the ability to move forward in any given situation uncontrolled by difficult emotions. That doesn't mean you don't have them, but it means your behavior doesn't have to be controlled by them. In other words, you can't stop the waves, but you can learn to surf. Maybe John Kabat-Zinn said that. I don't know, someone said it, not me. Okay, so I'm not going to spend much time on this because I actually don't have it. So, you know, so it's interesting, all of the different publications. In terms of clinical publications, what are the areas that are being looked at? And in February, these taken from American Mindfulness Research Association Monthly. It's a wonderful journal if you don't know it, by David Black. Anyway, most of the publications are in healthcare. Most of the literature is in healthcare. And why? Because of the medicalization of mindfulness. And I would say because beginning with JKZ, but really Zindel Siegel and Mark Williams and John Teasdale, the work of MBCT, because of the randomized control trial, the rigor of that study, paved the way and opened up the floodgates for research and multiple adaptations, because what they produced was a protocol made publicly available. It's like a recipe for delivering this work, and it spawned so many adaptations. And because it was deliberately developed to treat a condition, depression, which is, you know, a massive problem globally. So many years lived with disability and lost to disability, as you know, and lost period. And so in this way, it lent even more credibility, and it was a very focused modality. But then, of course, spawning many other focused modalities, when really, I think mindfulness, we can see it as transdiagnostic or transphenomenological. But this is another discussion. You know, I actually think the production of all these modalities doesn't make sense. It's not scalable. It's too expensive. You're using the same vehicle for different conditions. But anyway, that's another talk, which we're not having now. But, you know, Gottnick in 2015 did a big meta-analysis and systematic review of systemic reviews of MBCT and MBSR compared with treatment as usual and weightless controls, and really found the biggest effect sizes for depression, anxiety, stress, again, do we know what we're talking about, quality of life, and physical function. And, you know, there's a lot of neuroscience. Norm Farb is a big researcher in this area. But one of the things that I think is important in his research that he's done is that he's been looking a lot at what we call narrative versus experiential self-referencing. And I quite love this as a concept because I think it helps to map what we're doing when we're working with ourselves and when we're trying to understand. It's a way of understanding, a way of knowing or thinking about what we're doing when we're practicing. And so one of the things we're doing is, you know, a person's subjective sense of their physical and mental health is predominantly located in this narrative self-referencing realm versus the experiential self-referencing realm. And these, you know, different areas of the brain are responsible for this. So, you know, ways in which we evaluate habits that we have can cause us suffering. So, hi, how are you today? And then we appraise this and we may have an initial reaction, which then it's like, oh, how am I? Oh, and then I start thinking and ruminating and, contemplating. And this, of course, these sort of habits can then really affect our well-being. And so when we think about what happens when we meditate, now, of course, we need narrative self-referencing. This is how we define our sense of self. The story that we have about who we are, we carry through the world. One of the things that can help us, I think, with mindfulness, whether we are healthcare workers or otherwise, is to help to disrupt the story we have about who we believe ourselves to be, and to start to develop a view of self as process and changing. But it's hard because we need this, right? Like our narrative sense of self is responsible for goal setting, for enduring meanings, for memories, for reasoning, for judgment and planning. Without it, we'd be pretty chaotic, as Norm Farb says. Too much experiential self-referencing and we would have chaos. Too much narrative self-referencing and we are rigid. So experiential self-referencing is really a big part of what is being trained in mindfulness. And this is happening through this training of attention to all of these aspects of experience that come and go and that are really located in the present, right? Like your body sensations are happening now. And it helps to kind of deactivate this narrative self-referencing, to de-emphasize it, if you like, and also helps us to begin to regulate emotion, because emotion also shows up in the body. So we're beginning to train our attention over and over in these ways so that we can begin to have this, as I said earlier, this other place to go. So you're in a crappy meeting. I don't know, maybe you have a manager or a boss and you're feeling really angry, and you can feel that you are about to say something that you might really regret. So can you get that space? And rather than blurting out whatever that thing is, could you bring attention to sensations in the jaw? Oh, the jaw is really tight. Wow, anger's here. Oh, furrow in the forehead. Oh, can I just sit with that now? So this becomes the focus of attention rather than the big story or how mad you are at that person, if you like. So, this is very recent with Goldberg and Riordan. They did, it just came out recently, where they did this, really took a big look at mindfulness-based interventions and did a systematic review of only randomized control trials, which obviously, as you know, this is preferable to a lot of the other ones like the pre-posts, et cetera, quasi-experimental. So what they found in these 44 meta-analyses of 336 unique trials, looking at over 30,000 people, was that the most common problems looked at and the most common outcomes were psychiatric, so relating to psychiatric symptoms, which again makes sense if we track back to MBCT, right? Because really MBSR was for chronic pain, much more transdiagnostic. MBIs are superior to active and specific controls for psychiatric disorders, but where there was the most evidence was in substance use, smoking, and depression. But the others, the effect sizes, while present, were small. And they were superior to passive controls, but there was no significant difference with substance use. But at follow-up, MBIs were superior for health care providers. So it looks like, now while these effect sizes are small to moderate, there was at follow-up still effect for healthcare providers engaging in these kinds of practices. But understanding, of course, that it's not like healthcare providers are a huge population that have been examined. And they saw at the end that effect sizes obviously would be smaller and less often significant when compared to active controls, except for MBCT, which was actually superior to other evidence-based treatments. Problems are many, but a few of these were a few consistent moderators, like, for example, does dosing matter? How much mindfulness do you need? And there was little reporting of adverse effects. Although where adverse effects were being reported, they weren't that big a deal. There were only like 4 or 5 studies though that looked at it, but they seemed to be minimal. However, as many of you probably know, although I hated it when I was in medicine and like my attending would say, as you know, because I didn't know, was that, there's a great interest in looking at adverse effects. Okay, there's a great question in the Q&A. Let's see if I can even answer it. Yes, please go ahead.
So I'll read this. So the question is, interested in your thoughts about how traditional forms of prayer from major religious traditions, Islam, Judaism, Christianity, for example, overlap with mindfulness practice or help achieve similar aims of dealing with this stress?
It's a good question. And some of the research that I was looking at for this talk shows that one of the strategies that people use and report as helpful for dealing with stress and burnout are religious and spiritual practices such as prayer. I have not looked at that literature, but I do think that since we don't know a lot about the mediators and moderators, and we don't know in terms of what things like prayer or a lot of other contemplative practices, what's helping or what's really going on, it's hard to say. I mean, I do know that with respect to something like transcendental meditation, when I think it might have been, I don't know if it was Hoffman or Goldberg, if it was a long time, in 2000 and I forget, 10, I think. One thing they did find was that transcendental meditation, where you're focusing on a word, did not affect mood. Now, obviously that's a very different thing than what one is doing with prayer. But I mean, you could argue that, depending on the kind of prayer, are we bringing compassion to self and others? And we do know that those of us who are more compassionate toward others and who are, more giving and so on and are of service tend to be happier than those who are not. So I'm really like just talking off the top of my head. I like this. Janelle says, it seems that prayer gives us power while meditation brings self-agency. Yeah, maybe, although some people refer to mindfulness as a superpower when they're teaching teens. Anyway, so just lastly, just with respect to the research, here's really what we see. We need a lot more to know how useful this is, but when did that ever stop us in healthcare from adopting anything? And as a good colleague and friend of mine said, he said that if we just practiced evidence-based medicine, he was a psychiatrist, but he's a psychiatrist, by the way, we would go to work at 9 o'clock and we would go home at 9:30. So take that with a grain of salt. Okay, so let's just finish with a brief breath practice. So once again, closing the eyes, turning the attention inward. Choosing a place where the sensations of breathing are most dominant for you. And then letting go of this brief practice and opening the eyes. And just to say that mindfulness of breathing helps us, again, to have an anchor from which to witness difficult experience, unless the body and the breath are not a refuge for you, if you've had a certain kind of trauma. Helps prevent attention from moving into negative thoughts and emotions. It is attention orienting. And it also helps us to turn toward the difficult. So on that note, I would just leave you to say, maybe if you want to, this week, you can think of a stressor, something manageable that you can work with using a practice, maybe just using the 3-minute breathing space, or some way in which you might bring mindfulness to work with it this week. And that might be using the breath, it might be using the 3-minute breathing space, it might be just serving as a witness or going into the body, focusing attention there, or maybe stepping back and figuring out how to address it. So I would just like to say thank you so much for all of your time and attention. I don't know if there's time for any other questions, but I really appreciate you being here and for inviting me. It really was a pleasure. And I wish you all the best during this very interesting and difficult time that we are still in. And you're
Thank
so
you.
welcome.
Thank you. Thank you, Dr. Rockman.
Thank you very much, Pat.
Oh, you're so welcome.